How many of you have done a lean project in your emergency department? Okay. So you can chime in, you can add some of your comments and so forth, but just want to take you through an overview of some concepts. What is lean? When should I consider using it? And what are some examples of some lean success stories? Okay, so that's really the goal for the next 30 minutes or so here. Just got to put a seasonally relevant comic in, little slide in here. We give away all our product. We don't make a dime. I'm telling you, Santa runs this place like an ER. That's, I guess, hopefully by the end of this course, we'll be able to convince folks that that's not how we run our emergency departments. Lean is when you remove everything that is not necessary. Okay? Every block of stone has a statue inside it, and it is the sculptor's task to discover it, Michelangelo. Okay? So that's what lean is. It's really getting rid of everything that is not value added. More value, less work. More value, less work. That is really the key theme with lean and how to do it. Okay? Just to let you know, there's a couple slides here, and I'll try to highlight them as I go that aren't in the handout. I just did a course. How many of you are members of the American College of Physician Executives? Something to consider. It's an interesting organization. They have some good leadership skills, leadership courses, and one on reliability science I went to a couple weeks ago. So I got some concepts from that I put into this. But if you think about what we do, a production practice, the lean theory is that it looks at the expenditure of resources for any goal other than the creation of value as waste, and therefore a target for elimination. All right? So how do we define value? We're going to hear a lot more about value, and I'm going to talk a little bit about some of the reform ideas later this afternoon. And one of the big themes that you might hear is let's pay for value rather than pay for volume when it comes to healthcare. So what is value? Value is quality, defined by patient satisfaction, outcome, and service. Safety. So quality over cost over time. So it may not necessarily be the unit cost of a particular service, but it's the quality as far as safety, satisfaction, outcome, over cost, over time. That's value. A couple of key lean definitions and selected terms. Flow. Progressive achievement of tasks along the value stream so that a product proceeds from design to launch, order to delivery, and raw materials into the hands of the customer with no stoppages, scrap, or backflows. Okay? That's very lean-esque terminology. That's right out of the book. I don't know about you, but the emergency departments I've worked in can't be really characterized by no stoppages, scrap, or backflows. All right? But that's the concept of continuous flow. I'll also point out this concept of value stream, which is a concept of trying to understand the whole mapping of the process it takes to create our product, a visit to the emergency department. And events that contribute to value for the patient are part of that value stream. Right now, if you map out the stream of a patient coming through the emergency department, in all of our departments, there's opportunity for waste reduction. There's no question about it. Tack time. That's simply the amount of demands divided by the total time divided by the amount of demands on the system. Okay? So it sets the pace of production that your system needs. It really becomes the heartbeat of customer demand. It's your volume demand over time. It can be patients per hour, or you can flip that into minutes per patient, minutes per procedure. I think the minutes per patient is really the key one for us, because as that same shape in all of our ED volume curves, our demand curves throughout the day, as it starts to pick up in mid-morning and then accelerates through late morning and early afternoon. I don't know how many of your tracking systems can identify how many patients have been registered in the last hour, how many patients dispositioned in the last hour. That's one of the things we have on our tracking board. And you can see whether you're keeping up with your tack time, which is this element of customer demand. Because if a patient is arriving every 6 minutes during your peak volume, you need to be keeping up with dispositions at a similar rate. Otherwise, you're going to fall behind your tack time, and you're going to end up with backlogs, backflow, and waste in the system. Okay? There's a couple of good articles. Really, Toyota was one of the companies that was very instrumental in this. And actually, Edwards Deming, W. Edwards Deming, went to Japan after the Second World War and worked with Toyota and other industries in Japan, looking at trying to understand the manufacturing process and really understanding systems and how systems work. Really, when it gets right down to it, that's what we're talking about, is systems. And a great quote from Deming is that a bad system will defeat a good person every time. Okay? And I really think that that captures healthcare in a nutshell sometimes, which is bad systems that are defeating good people. And that's what's really taking away a lot of our energy in healthcare. And that's a quote from Deming looking at systems perspective. But if you think of it from an operations point of view, from Toyota, a couple of themes come out across continuous improvement. And that's really what the theme is from Toyota, is that continuously looking at the system, continuously trying to identify waste. The challenge is to look at from a long-term perspective, is to meet the challenges over a long time horizon with this concept that we're going to continue to improve what we do. Kaizen, continuous improvement. Kaizen, that's where the Kaizen invents. For those of you who have heard about Lean, sometimes they'll start with what's called a Kaizen event. And it's often 2 or 3 day where you bring all the stakeholders together and you really look at pulling together and understanding and mapping the whole process. We'll talk more about that. And then this concept of going and seeing for yourself. So easy to sit up in the front office or in the conference rooms and think about, oh, what's going on with our data, what's going on with our process, when really we just need to go down there and look at the front door of our emergency departments in our waiting room and see what's happening and what's causing some of the problems. And then if you look at, that's the system side, but then on the other side of the coin is respect for people. And this really comes through in Lean work, which is the concepts of teamwork and respect for people. And the idea that you really do trust the people that are at the front line to come together and address and find where the waste is, because they're the ones that are doing the work day in and day out. So there's a reference that is in your handout from Harvard Business Review for those of you who are more interested in this, to take some time and read through some things that have been some good examples from Toyota and others. So waste, or muda, is activity that doesn't add value. So, and it is in spades in healthcare. 7 types of waste. In your handout, there's very detailed discussion of all the waste. This kind of summarizes it here, that the 7 different types of waste include these types of categories. Overproduction, work that's not needed today. A lot of work that goes into all the forms and all the infrastructure that we create. Any waiting is considered waste. Unnecessary transport of the patient. You know, how far, when you're building your new emergency departments, how far away does radiology need to be? You know, it's no longer the case that the radiologists need to be next to the equipment that's being done to do the procedures. So incorporating radiology, bringing that up close to triage so that you can have a rapid turnaround. The transport time there is certainly a potential waste in the process. Overprocessing, and we've spent a lot of time talking about that with the talks you've heard about electronic health record and so forth, is what types of activities are we best suited for the most expensive people in our departments, and we have a lot of examples of overprocessing using us to do tasks that could be done where really aren't the best use of our time and our resources. Excess inventory, unnecessary movement, that's a key one. Where's the equipment? Where is the equipment? I'm going to give this example later in the talk of one of the most lean operations in healthcare, which is Minute Clinic. And I am told by Clay Christensen, who wrote the book Innovator's Prescription, trying to talk about the example of Minute Clinic, that if you walk into any Minute Clinic in the United States, the exam room will have the same layout, the same drawers, and the same content in every Minute Clinic exam room across the country, which is certainly not the case in our emergency department. But this unnecessary movement, trying to find the equipment you need to take care of a patient, certainly is waste in our system. And defects, you look at hospital-acquired infections, non-prime the first time, that's another category of waste. So these are the types of categories we're looking for when we're going to go out on this hunt to reduce waste in our emergency departments. So this continuous process really starts with a map of what's happening. A value stream map identifies each step. You start with the current state. And this is really kind of an enlightening experience when you get all the different stakeholders together, because it's multidisciplinary. I think any one of us could really map out all the steps that we do for the patient during their emergency department visit. But there's a lot of things happening that we're probably not aware of. And some of those things happen just because it's the way we always did it. And it may or may not help get the key interaction of the visit, which is the patient with the decision maker for their plan of care, to occur as early as possible. And to then, the key interactions once that happens is to execute the plan of care for that emergency department visit. And a lot of the activities that happen may or may not support the value of those two key activities. So once the current state is identified, there's lots of opportunities for potential waste, and then there's a second map that's created around the future state. Here's some key, this is one of the slides that's not in your handout, all right? So I'll highlight one reference here, learning to see Mike Rother, John Shook. Mike Rother, R-O-T-H-E-R, and John Shook, S-H-O-O-K. It's learning to see, looking at seeing where the waste is and seeing what processes look like, all right? A value stream map is a visual display of all the steps necessary to complete the work. All the steps necessary to complete the work. The creation of that is led by the staff who are actually doing the work. All right, that's really key. It has to be the people that are doing it day in and day out. Current state maps are developed to understand how the work is done today, and future state maps give us an opportunity to develop processes with new eyes. Okay, so it's like, what parts of this can we really actually let go of? All right. How to do it? One of the key pieces of any lean project is to identify your boundaries. You got to have a very tight scope on these projects. So if you're going to say, I'm going to look at the admission process in the emergency department, okay, you could say that the key start point of that process is when the order is written for the patient to be admitted to the hospital, and the end time for that process is when the patient is being transported out the door of the emergency department. Okay? So two clearly time-stampable defined events, and you're going to look at all the events that take place between those two events. If you don't set up clear boundaries at the beginning and the end of what you're trying to do, you're going to end up not having a lean project, if you will, because you're going to expand beyond all those boundaries, and pretty soon everything gets loaded onto this, and you're trying to solve world peace with one project. All right? And that is not what lean is about. Lean is about doing small experiments day in and day out, actually going out and just doing something to see if it would make the process more efficient. Not about redesigning and coming up with the perfect solution so that it can be implemented everywhere. That is not lean. All right? So define the boundaries clearly. Develop the current state using this go and see tool. So you're really going down there and really looking, because that's the other thing. Even when you get everybody in the room, we can talk about what we think actually happens, but sometimes until we actually go down there and look, we'll see that what we think is happening isn't actually happening on a day in and day out basis. Identify small cycles of change, small experiments, and then test and test and test. You can do an experiment with 3 people in 2 to 3 hours just to try to understand what a pilot idea might look like. You don't have to train 350 people in your department with an implementation date 4 to 5 months from now to get everybody on board and then find out that that small test really wasn't exactly what you were looking for. And then once you start these tests of change, you continuously improve and work towards that future state map. So that's the basic concept of what a lean project looks like. A lot of times they'll have what's called an A3 tool. That's a one-sheet description that says this is what our project is. It has the aim, what are we trying to do? What's the purpose of it? It has the measures that we're looking at. So maybe it will be the total time from admission decision to physical departure from the emergency department is one of our key metrics. It has the changes in the process that are being proposed to get from today's map to the future map. It has the team, who's championed this effort, and it has some results. Here's where we are so far. One sheet of paper, A3, that's a good way of kind of framing up what the project looks like. Okay? Warnings. This list down here are things that you really got to watch out for as things that are going to jeopardize the success of your lean project. Weak representation from frontline staff. If you look around the room and it looks real like, a lot like a supervisor's or manager's meeting, you have a problem. Okay? It doesn't mean that we can't be in there as leaders. It just means that you got to have frontline staff involved from different disciplines. Not clearly defining the start and the end of the process. If everybody can't walk out of the room and in 1 second say, oh yeah, we know exactly what we're looking at. This is the start, this is the stop. Then you haven't clearly defined it. Not testing. All right, I was just visiting the Mayo Clinic in Florida, and the CEO down there is named Bill Rupp. He's an oncologist, and he has done this for years. He was a CEO at some of the Mayo Health System sites, which are some smaller hospitals associated with up in Minnesota, close to Mayo Clinic, Rochester. And he's really been a champion of lean. And the culture down there now is that he feels like after being there a year, he can now walk onto a unit, and especially a few selected units, and just be able to ask anybody, so what are you testing today? What are you testing today? And they'll be able to tell him what little change they're trying today. And that's when lean has really started to become part of the culture. All right? That's not the case in my emergency department today, but I was very impressed with that. And you go into the break room where they do the sign out, and they have all these different little posters and ideas about what ideas worked, what ideas didn't work. Okay? So there's a real culture that says inviting frontline staff to say, we think this could be improved. Okay? So if you're not testing, that's a warning sign. If the current state map doesn't fit reality, you know, if it's what we really like to believe that's happening today, but it isn't actually what's happening today, that's a problem. And committing to the computer too soon. If you take the process and commit it too soon to a fixed protocol or something like that, without enough testing, that's probably a process that hasn't really gotten all the waste weeded out of it. All right? So I spent a little time on this slide so you can kind of jot down some notes and so forth. Apologize it's not in your handout. All right. So this is an example of a value stream map. Doesn't have to be some fancy Visio diagram. You know, it could just be on the wall, sticky notes, and et cetera, with lots of different notes and thoughts about where different changes could happen. Timelines are going to vary. If you're looking at a complex process, it could be several months. If you're looking at a very small process, it could be even shorter than that. Okay? And as I mentioned, you can have a culture that continuously is trying to improve different things. But the scope of the project is going to determine what the timeline will be. I would hesitate, again, it's not about the grand change that you're going to take your organization through. It's really about getting a culture of continuous improvement and clearly defined small processes with frequent small tests of change. Those who are closest to the work have to be engaged in it, otherwise it's not really going to work. Regarding measurement, and I've been guilty of this, Kirk can attest to that myself, that you do have to measure the processes where the potential waste has been identified. You need to do that in order to support these cycles. Cycles of change are often called the PDSA cycles, or Plan, Do, Study, Act, where you really look at this, you see what happened, you do need to measure. You do need to measure. But when it comes to measurement, as the quote goes, remember, weighing the cow does not fatten the cow. All right? Weighing the cow does not fatten the cow. So measurement's important, but if all you're doing is trying to get this grand sheet of measures rather than testing changes, you're not really addressing your systems. Okay? Measurement's important, but we're not serving the God of measurement. All right? And I've had some times when I've done that myself. What are you testing today? This is from Bill Rupp. Exactly, you know, walking around and asking people in your department, you know that you're starting to get toward a lean culture if people have the freedom to test something today. I've already made that point. Fujio Cho, who was the president of Toyota Motor Corporation in 2002, related to this, had this quote, which I think is helpful. All right? Again, this one is one that's not in your handout. We place the highest value on actual implementation and taking action. All right? There are many things one doesn't understand, and therefore we ask them, why don't you just go ahead and take action? Try to do something. You realize how little you know, and you face your own failures, and you can simply correct those failures and redo it again. And at the second trial, the second test of change, you realize another mistake or another thing you didn't like, so you can redo it once again. So by constant improvement, or should I say the improvement based upon action, one can rise to the higher level of practice and knowledge. So small cycles of change. That's the concept. Now, that doesn't mean we're going to just randomly experiment with, oh, let's try to do rapid sequence innovation differently today. I just feel like just experimenting with this process a little bit. We need to be careful about what we select, but giving people the permission, if the focus is in clearly defined processes, the focus is on process, and the goal is to eliminate waste, giving people the permission to take action and do small experiments and tests of change, and then sharing that with the staff to say this is what worked and this is what didn't work, can go a long ways to creating a lean culture. So what is culture? Shared values and beliefs of individuals in a group or an organization. So that's what the culture is, shared values and beliefs. But shared values and beliefs really drive our behaviors. And it's our behaviors that drive our outcomes. Okay? So it's so easy to have a culture of 1,000 points of no, where, we can't do it that way. 1,000 points of no. Oh, by the way, if you have 100 doctors, do you know what they call a vote on an issue of 99 to 1? A tie. Very good. Somebody heard it. Yes, a tie. 99 to 1. So 1,000 points of veto, 1,000 points of no. Really, when it gets right down to it, addressing the culture, and this change can take place over time if you have lots of different small empowered teams doing lean. What is it ideal for? Wastes in our emergency departments. Focus projects, clear defined scope. Try to get short-term wins that can help build the momentum and build confidence. Changes in the setting of limited resources. Let me just make a comment about this. It is helpful to have some expertise to get this launched, all right? And the consulting costs can be expensive. If you're going to bring in an outside lean expert to help do that. If you do that, if you make the investment to bring an outside lean consultant in, which I don't think is a bad idea, make sure that you're training the trainers within your organization so that you can gain momentum over time so that you aren't always relying on some outside consultant. Whenever you have a lean project, you have to bring somebody else in order to do it. Okay? So that part can be expensive, but once you start getting the momentum with that culture and are addressing very small, clearly defined processes, you can do a lot of this on your own, especially if you've taken that outside expertise to develop trainers within your own organization. Okay? Lean is not a complete electronic health record implementation. All right? The same person from the Toyota Corporation who had that quote said, to begin process improvement, we must first have a process. All right? So you have to have a process in order to be having this cycle of continuously improving it. So it's not necessarily the best approach for organization-wide implementation. Here's one example from our emergency department. It's actually a little different than some of the thoughts we're talking about from the front end. Okay? When I first came, I said, what do you mean? Why won't you just push them back if they come in and you have rooms available? This is the pull system. Pull is another lean concept that says it's a system of production where instructions from downstream to upstream activities in which nothing is produced by the upstream supplier until the downstream customer signals a need. Okay? So it's the opposite of a push. So if you're going to have a continuous flow in a system, you need to pull when you're ready to care for that next patient. So we now have a system of green lights that flash when we're ready to take a patient, And so you pull patients back based on the green light system. And it is true that if you look at pushing patients from triage, whenever there's an open room, just push them to them, and I was a big proponent of that. It is true that often those systems are pull systems in disguise. So in other words, they'll get pushed back to the room, but if the team is not prepared to take care of that patient, they'll often wait for a long period of time in the room. Okay? Here's our results. Looking at the implementation of the pull system, the red line is our volume, so there wasn't huge change in that, but it decompressed the variability around length of stay, and that for all comers it's just under 3.5 hours now. So it's about under 3 hours for, just about 3 hours for discharged and 4.5 for admitted, and that's in a pretty complex patient population. So the concept of pull certainly can be helpful as well. These are great, quick little list of things. Door to doc, fast track top 5, that would be like look at your most 5 common diagnoses in the fast track and say, how can we set this up, all right? I bet we all have opportunities around wound repair to think of lean strategies, and Jody Crane, Kirk Jensen, Sherry, a lot of other folks have looked at that, and we'll have some other talks about it, but pulling the medications and charging the patient as you're getting the next set of lidocaine, et cetera, out of the Pyxis, so you have it pre-set up, little things like that. Lab turnaround, radiology turnaround, et cetera. These are all good examples of lean implementation. I already mentioned Mayo Clinic and how they have approached standardization. Some may be as good as, some of you may be as good as Mayo Clinic's outcomes, but I don't think anybody's better if the question is, for the selected conditions that they have, what percentage of patients that are seen at Mayo Clinic have care that is delivered within evidence-based and recommended guidelines for those selected conditions? It was over 90%, and I know we're not close to that in many of our emergency departments. I'm not suggesting that Mayo Clinic is the answer for, it's a totally different thing than what we do, okay? I'm just saying that has been a disruptive innovation in healthcare, Mayo Clinic, and they have really shown through standardization how they can improve the reliability for, albeit a very short and defined set of conditions. They do have great reliability in what their process delivers. And Clay Christensen's book, The Innovator's Prescription, it's a big book, but it has some really interesting concepts about this. It's not a book on lean per se, but it shows how some of these, as we've moved from intuitive medicine down to very defined medicine, and that's not the case for a lot of our conditions that we treat, but for those that it is, we really do have the ability to create more reliable systems of care. Steps to learn more, there's a Lean or Six Sigma conference in this city every week, it seems like, or around the country. So there's lots of conferences to go to that are all about just Lean and Six Sigma. Six Sigma I didn't talk about, it's a little bit different, it's a different methodology, but they're very closely tied together, and a lot of consulting groups use each of these tools. That's what they are, they're tools. Some organizations have adopted this Toyota production system concept as their really overall theme for their organization. Virginia Mason in Seattle is an example, Park Nicollet in the Twin Cities as well. And the IHI has really done a lot of highlighting of these success stories related to Lean. But those are some of the things. I also listed some resources in your handout, Going Lean in Healthcare, the Harvard Business Review article I had there as well. Those are some of the resources that I think are helpful in trying to learn more about Lean. We talk a lot about this continuous improvement concept. And I want to close with this thought about it, is that many of us we want to hardwire our operations in our emergency department. And these instructors at this Science of High Reliability course a couple weeks ago in Tucson with the American College of Physician Executives that I was talking about, they were both from the nuclear energy industry. They were engineers, so they don't have a healthcare background, although they spend a lot of their time now in healthcare. It was very interesting, their perspective on hardwiring. And the theme that came from the nuclear energy industry is that nothing is hardwired. Nothing is hardwired. In every system, performance must be continuously wired faster than it unwires itself. And that's their approach to safety and reliability in the nuclear power industry. And I think that's why tools such as Lean are very powerful and useful in healthcare. They're not the holy grail. They're not going to solve everything. But getting that culture that allows us to continually look at where waste is in our processes and to continuously rewire performance, I think that's why it's helpful and why it's powerful. But nothing is hardwired. In every system, performance must be continuously wired faster than it unwires itself. And we all know that performance certainly unwires itself. There's no question about that. Related to these system dynamics is the theory of constraints. I don't know how many of you have read the book, The Goal. But if you're interested in operations and really trying to understand how production systems and bottlenecks affect flow and production, this is a great book. And it's kind of an easy book to read because it's a story. It kind of goes through, it's written like a novel, but it goes through the theory of constraints and understanding bottlenecks in complex systems, and it has a lot of applicability to what we do in our emergency departments. I do want to acknowledge a couple of these slides were from Jeff Norton. He works at University of Kentucky in healthcare there. He's one of the engineers that helped teach this course. I do recommend ACPE for those of you who are interested in trying to understand some more of these leadership and operations topics as well. Been a long morning. You've hung in there. I don't know if you have any comments or questions on this, or you want to chat about your projects. Todd?